Welcome to Health Professional Radio. I'm your host, Neil Howard. Real glad that you could join us for another segment. Going to be speaking with Dr. David Feldman, Chief Medical Officer at the Doctors Company Group. He's joining us to talk about the risk of mismanaged communications as indicated by a new study that found that oncology malpractice claims are often due to behavioral mistakes, including incorrect diagnoses, improper management of treatment, and improper medication management. Welcome to the program, Dr. David Feldman, and thank you for taking the time.
Pleasure to be here, Neil.
I did mention that you're Chief Medical Officer of the Doctors Company Group. Give us a bit of your background and talk about what the Doctors Company Group is about, and then let's talk about mismanaged communications as it relates to treating breast cancer patients.
Sure, happy to, Neil. So the Doctors Company Group has the mission of building the preeminent organization for service to healthcare. We're a large group of companies that includes significant presence in malpractice insurance for both physicians and managing self-insurance programs for large hospitals. We do some surplus and excess lines as well in healthcare, and we have a healthcare consulting arm that works with doctors' offices in telemedicine and other areas. So our role is really to service healthcare, and that's the place we enjoy working in. Personally, I've been in this business per se for about 10 years. I'm a plastic surgeon by background, spent many years at a large urban hospital in Brooklyn, New York, where I served in a number of roles, including administrator for operating rooms and patient safety officer. But now really love working with physicians, nurses, and other clinicians in helping to reduce risk and improve patient safety.
You know, years ago, the word malpractice seemed to be everywhere. No matter where you turned, there was malpractice this, malpractice that. Is malpractice claims still as prevalent as they were in past years, or have they kind of slacked off?
Well, that's a great question, Neil. As it turns out, the number of claims, what we call frequency, is probably leveled off. The problem is the severity. That's what we call the dollar amounts. We call that severity. The dollar amounts keep going up. There's lots of reasons for that. Probably we can do another podcast to talk about that if you'd like. But it's a very expensive proposition. And the unfortunate part of that, of course, is it takes money away from hospitals and doctors and other healthcare institutions that could be used for more important things like adding more nursing staff, CAT scans, MRIs, and that kind of thing. So that's really the state we're in with malpractice.
Malpractice claims, are they normally credible? What do you think the percentage of unfounded claims are?
Well, there's not a lot of data that's so reliable on that because of the lack of significant databases that don't have their own biases. But we believe that a lot of malpractice really has more to do with bad outcomes than bad care. And it's unfortunate that some patients, based on the disease they have and things we know go wrong without being preventable, will have what we call an adverse event or a bad outcome. And then in those cases, if patients are really upset, they may decide to bring a lawsuit. It's still pretty unusual, but that's part of why and the importance of this discussion we're having today about communication, because we know when doctors and nurses and other healthcare providers use excellent communication skills, it's much less likely for a patient to bring a lawsuit, even when there is a bad outcome.
I've had medical procedures, a few of them, and without fail, I get a piece of paper that outlines what I should do, what I shouldn't do, what my driver should do, all of these different things. When it comes to communication, are there different, levels of communication? Is a piece of paper with instructions a lot less effective than a sit-down face-to-face with your provider?
Neil, I think you need both. And in fact, there's lots of new ways of really communicating with patients at multiple levels, especially now. We know there's been an explosion of telehealth, so there's an opportunity for having a conversation with patients over an audiovisual connection that can be recorded, much like this podcast is, and that can be played back by a patient and their family. There are physicians that are actually doing that. They're recording the discussions they have with patients about pretty important things for patient care. And patients, they're upset, especially if it's a new diagnosis, say a cancer diagnosis, and it's good to be able to hear that again. So having that recording to be able to review at home with family members so they really understand what's being said is important. Having it in writing is important. And there are some other tools that many physicians are using that help the the patients and families really understand and what the recommendations are so they can follow them and optimize their treatment. So I think it's a multifaceted approach that really gets the best results.
Well, let's talk about some of the reasons that these claims are brought. You talked about claims after a diagnosis. Obviously, an incorrect diagnosis is a huge problem. What about just simply the diagnosis itself?
Yeah, so when we looked at this study of claims, of oncology claims in cancer, that is, there were three main points that we identified. And the first was diagnosis related. And interestingly enough, you would think, well, these patients already have a diagnosis. So what's going on there? And some of this are what we call secondary diagnosis. So a patient has a primary cancer diagnosis, say they have colon cancer or breast cancer, and they have another problem. And it turns out they have a metastatic problem. That is, the cancer has spread to some other part of their body that's causing them symptoms somewhere else, in the bone, say, or somewhere else. And those kinds of things sometimes elude physicians. So what we often tell them is, our physicians, is to pay attention to these kinds of things and not be subject to what we call the biases of assuming that whatever their problem, the problem they're having is due to their primary cancer, that there may be something else going on. It may be cancer, it may be some other diagnosis, right? Maybe they're having pain in their chest and someone thinks it's a heart attack, and it turns out they've got metastases or cancer in their ribs that are causing them to have pain, right? So we need to be sort of thinking about these things and have them top of mind and not immediately go to something that seems the most obvious, but really be careful about that. And then, of course, there's missing a primary diagnosis. Patients come in with all sorts of complaints and thinking that it's one thing when it may be another. These are difficult diagnoses to make sometimes, and there's lots of recommendations we can make to help avoid that. But that's the primary thing we found was related to some type of diagnosis, either missing a primary diagnosis or, as I mentioned, missing a secondary diagnosis. The two other areas that we found in this study were that the treatment was inappropriate, meaning that a patient was given the wrong dose of a chemotherapy, or they was given radiation therapy in the wrong way or inappropriately. And then the final area was around medications, and that's not surprising. Patients who are undergoing cancer treatment get lots of different medications, and they're dangerous medications. In fact, they sort of have to be if the goal of this treatment is to eradicate cancer, right? They're pretty strong drugs, so we want to be careful about how those are managed. So those are the top three things that we found.
A physician can't check for everything. It kind of puts the practitioner in the crosshairs.
Yeah, it's tricky, isn't it? And we often expect that physicians, can do everything, and we can't. We're humans. But it's important, I think, and this is something that the people in the patient safety world have realized. Doctors are human beings. Nurses are human beings. And so what we want to do is create a system, a healthcare system, that keeps us from making mistakes, that keeps humans from making mistakes. So what do I mean by that? Things like decision support, right? Something in your electronic medical record that says you just ordered this drug for this patient, and we know that's probably an inappropriate drug. Or we ordered a drug the patient's allergic to. Now, that seems sort of obvious. Why would a doctor give a patient a medication they're allergic to? Sometimes it's not clear that the drug you're ordering is related to something they're allergic to, and sometimes, as I said, doctors and nurses are human and they forget. So the system is there to remind us that, hey, this is not the right drug for this, or you want to use a slightly different dose, or you want to order a CAT scan rather than an ultrasound, or the reverse, right? So those are the ways we can help ourselves to get patients the best care they can and still understand that, doctors and nurses are fallible, right? They're human beings too.
Especially during this COVID-19 pandemic, how much of just the urgency of this pandemic is contributing to this mismanagement?
Yeah, that's a great question. First of all, we're not going to know what the malpractice claims from this pandemic are going to look like. Like everything else in the world of malpractice, we're always delayed by a few years, so we don't really know. But I would guess there's two ways to look at it. On the one hand, you're right. People are distracted. They're upset. The world is a tough place to be in these days in the middle of a pandemic. On the other hand, many have called this explosion in virtual medicine, in telehealth, we call it, the silver lining of the pandemic, because it's something that we all believe is a great tool. It's only a tool for healthcare to use in their treatment of patients, and yet we've been very, like many things in healthcare, it's sort of come along slowly. And in the last 6 or 8 months, it's sort of exploded. And I think many of us believe it's a good thing. It's allowed us to have access to patients that we wouldn't necessarily have easy access to, and vice versa, for patients to have access to the healthcare system. So I think many of us are taking advantage of that. And in the world of oncology, that's critical, right? These are patients who are often immunocompromised. It's not safe for them to be anywhere. Forget the pandemic. That's just made it worse. But here now everybody wants to be separated, right, because of the social distancing and so forth. So it's given us the opportunity to be able to access patients and for patients to access their healthcare providers in a way that's safe, understanding that a virtual visit is not for everybody. There are certain things that we really need for patients to see us in person. But I think there's a way for physicians and other healthcare providers to have a conversation with a patient even virtually and then say, I'm really uncomfortable doing this by telephone, by Zoom, whatever it is. I need you to come in. And that might actually make patients feel better about doing so than just saying you need to come in at the get-go, right? Because they know the doctor's already had a conversation with them. They have a sense that there's something that they really need to see in person. And I think, frankly, especially now in the end of October, hospitals and doctors' offices probably are safer than going to your supermarket, right? People are very aware in healthcare facilities about what's going on. They have protection for you, the staff, the physicians, and the patients and families who are there. And you don't know who you're going to meet in a supermarket, right? And
Absolutely.
People are concerned about who's wearing masks and who's not. So I think it's an opportune time for us in healthcare to really assure patients that if we think you need to come see us, you really do. And that means coming for a follow-up care, or even, we worried in the world of cancer about missing primary diagnoses. The number of mammograms and colonoscopies that were not done during the height of the pandemic, and the first height, I guess, is huge. And I don't know if we're going to be able to catch up. But I think now patients really have to understand they need to get these tests done, and it's safe to do so, or we're going to have a worse problem than coronavirus. Correct?
Absolutely. Well, as we wrap up, Doctor, give our listeners a website where we can learn more about your group and maybe learn more about oncology malpractice claims.
Sure. Happy to. So the doctors.com, the first thing you'll find at the very top is a whole section about COVID. For our audience that are healthcare providers, we've got a long list of topics. In fact, we added about 34 new or updated articles since February and have had, hundreds of thousands of views with almost a 50% increase in our traffic. So people are looking at this, and it's open to anybody. You don't have to be one of our insured. So please take a look at thedoctors.com. There's a long list of resources, articles that are constantly being updated about telehealth, reopening a practice, about burnout, treating stressed patients, wearables, and COVID-19, pretty much anything and everything you'll want to know about getting through this pandemic. So,
well, I thank you for joining us here on Health Professional Radio, Doctor.
Neil, it was a pleasure. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download at SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.